Good afternoon and welcome to our webinar. Today's topic is the management of the diabetic foot. We have some great presentations lined up for you. My name is Katie Flanagan and I'm the podiatry manager here in the Midwest. As many of you may be aware, we have been running a Care funded project since the beginning of 2020. It's called a podiatry-led pathway for the timely provision of footwear and orthotics in the community. The Care funding for this project has provided staff and stock to tackle the long waiting list for footwear and orthotics in our area. It has also facilitated us to keep a stock of offloading devices in store for immediate issue when a patient first presents with a foot ulceration. This has led to improved healing times and a reduction in hospital admissions for this vulnerable cohort of patients. We would like to extend our thanks to Care, POBOL, and also our local PMO, Finance Department and Management team here in the Midwest, along with our recently retired podiatry manager, Carmel Devine. Without all this support, these projects would not succeed. On the ground, we'd also like to acknowledge all the hard work of our nursing colleagues in the shared care of our patients with diabetes. Before I introduce our first speaker, a couple of housekeeping points. Number one, can you all please put your microphones on mute? If there's background noise, it will interfere with the presentations for all other listeners. Point two, all questions will be kept to the end of the final presentation. Please utilize the chat box to put any questions you have as we go along. All presenters will be available after the final presentation to answer these questions. And the final point is a reminder that today's broadcast is going to be recorded and it will be put up on YouTube. The link to that YouTube presentation will be sent to the email address that you registered with Eventbrite for today's webinar. Our first presentation today is from Joanne McKenna, Managing Director of PPL Biomechanics. Joanne and her husband James both trained and worked as podiatrists before creating PPL in 1996 in Cork. Over the last 25 years, Joanne has developed and presented numerous biomechanical-related educational courses. Joanne has embedded in PPL the ethos that patient care and outcomes is the primary concern of healthcare professionals. Therefore, research-led and technical support, training and education, alongside a practical, cost-effective approach to prescription, is central to what they do. Thank you, Joanne.
Hello, I'm Joanne McKenna from PPL Biomechanics in Cork. I'm a podiatrist and I'm passionate about preventative medicine, multidisciplinary practice and offloading. International guidelines tell us that pressure offloading is critical for the prevention and healing of neuropathic diabetic foot ulcers. Whilst multiple interventions are typically required to heal ulcerations, such as local wound management, infection management and revascularization, the guidelines state that pressure offloading is arguably the most important intervention of all. Because of this, offloading is interwoven into HSE programs of care and Slauncher Care initiatives. This is no surprise, as research shows both the healthcare and amputation costs related to diabetic foot ulcers is far from positive. Pressure is everywhere in 2021. Our resources are stretched. Unfortunately, we can't offload all these pressures. But it is often simple and always cost-effective to offload pressure on the diabetic foot, using basic mechanical principles and providing our patients with an offloading solution. We can use a combination of mechanical principles and products to offload the foot. We can reduce movement, steer force, reduce pressure, deflect pressure, and support the foot shape. The international guidelines provide us with advice on how to do so based on risk. There are many offloading solutions and products: total contact casts, walker boots, offloading shoes, foot orthoses, and preventative medical grade footwear. Offloading solutions can be custom made to provide an exact fit, which is most important when foot deformity is present or impending. All offloading solutions have pros and cons and different levels of mechanical and therapeutic effectiveness. Product selection and prescription should ideally be based on patient risk, patient needs, and most importantly, international guidelines. Foot shape and mechanics should always be considered when offloading. Do the offloading devices increase the contact area under the foot to reduce pressure? The walls of a walker or TCC can bear 60% of the plantar load. Would a boot be better than a shoe? Is the sole of their footwear rigid, semi-rigid or flexible? Flexible soles encourage movement and will not steer force. And if there is foot deformity, should custom devices be prescribed? It may cost more. Is it necessary to actually offload? Nobody wants to wear an offloading device. They are not fashionable, they look different, feel different, slow you down and interfere with your daily life. But offloading devices do reduce the burden on healthcare resources. They prevent ulcerations, provide quicker healing times and reduce visits. They prevent hospitalisation and reduce the risk of amputation and mortality. Patients are at the centre of all our care plans. Early intervention with offloading can address some of our patient needs, but prevention and quicker healing times are not the full story. Offloading early and effectively can have much wider impact on mental health and wider needs. Nobody wants to visit clinics weekly or to be hospitalised. The impact of longer healing times on mental health, especially during these challenging times, is yet to be fully discovered. Every person wants to keep moving, maintain their independence, be busy and enjoy active daily lives. The CH03 Midwest Foot Clinic, working from 2 clinics, one in Limerick and one in Clare, provides a working example of how the community podiatry team, by prioritising early offloading, made a significant impact on addressing patients' needs and escalated service demands. This Launcher Care supported service through Project SIF 343 adopted new ways of working which facilitated delivery on the Launcher Care principles of right care, right place and right time throughout the pandemic. The first phase focused on reducing lengthy waiting lists for biomechanical assessment, the development of care plans, and where appropriate, the provision of aids and appliances, including offloading devices. The second phase centred around the busy community wound clinic. Patients' reluctance to attend acute settings and restricted outpatient services during the pandemic meant the community wound clinic accepted significantly more referrals from acute services via integrated care pathways. The Midwest Podiatry team rose to these challenges of increased workload by caring for more patients with and without diabetes, and also managing and healing many more wounds. The project outcomes demonstrate the value of integrated care and multidisciplinary collaboration in ensuring the patient comes first. The Midwest Foot Clinic podiatry team worked in collaboration with their colleagues in other disciplines, such as nursing services, physiotherapy, occupational therapy and dietitians. Established referral pathways with GPs, orthotists, prosthetists and acute services were strengthened and maintained. This collaboration with colleagues, referral networks, suppliers and service providers helped to both prevent and heal wounds. The project also engaged with other stakeholders to outsource specialists offloading services and stock and custom-made offloading devices. Multidisciplinary joint clinics were held with orthotists and prosthetists from clinically led prosthetic and orthotic specialist service providers. Patients with more complex foot shapes and mechanics, and therefore greater offloading and healing challenges, were referred for assessment. These patients often requiring the prescription and manufacture of a more complex and custom-made solution. Leaner ways of working were established with suppliers by the provision of call-off purchase orders, which allowed orders to be placed with suppliers weekly on a needs basis by the project manager who understood the technicality of the products being ordered. This service-governed approach eliminated delays, unnecessary stock holding and returns, and significantly reduced the administration time and costs. Supply chain planning and delivery of the right products at the right time occurred throughout the pandemic and this Brexit transition. So when are custom-made offloading solutions and specialist service providers required? There are many types of off-the-shelf stock offloading solutions, such as walker boots, pressure-relieving AFOs, offloading shoes, foot orthoses, and preventative medical-grade footwear. Advanced foot deformity, with or without complications such as diabetic neuropathy, will not be accommodated in off-the-shelf devices or footwear. Complex foot shapes, complex lower limb biomechanics, and delayed healing often require the prescription and manufacture of custom-made lower limb offloading solutions. The value of an early input from orthotists for complex and non-resolving cases is to achieve effective offloading and optimize biomechanical alignment, and should always be considered. So to sum up, could you be offloading more? Is offloading part of your first line management strategy for your patients presenting with a diabetic neuropathic foot? Offloading is the best validated strategy of all current interventions, and the evidence base for much of what we may consider as routine clinical care is thin at best. Is offloading embedded into your wound care strategy? Are you dressing or debriding wounds without offloading them? How long is it taking for the ulcer to heal? Will it heal? Will they be hospitalised? Are you preventing deformity and reoccurrence? How expensive are the dressings? Are they adding any value? Can you do more to offload healthcare resources and improve patient care and outcomes? I'm pleased to let you know that PPL's offloading training programs will be returning soon in an online format. If you want to know more about offloading devices and receive notifications of upcoming training and education, please go to our website and register. Thank you for listening, and I hope you found this presentation useful in offloading some of your own pressures.
Thanks, Joanne. That was really interesting. I'm looking forward to the questions you're going to get at the end of all the presentations. So on to our next one. This next presentation is from Elizabeth Carrick and Marilyn McDonough from UHL Podiatry team. Elizabeth graduated from Queen Margaret University, Edinburgh in 2004 with a BSc Honours in Paediatric Medicine. Upon qualifying, she worked for the NHS in Scotland as a community podiatrist before returning home to work in the community in Clare. In 2012, she established the Acute Diabetic Foot Service in UHL and is currently in her final year of a master's programme in lower limb preservation with the University of Ulster. Marilyn graduated from Salford in 2011 with a BSc Honours in Podiatry also. After qualifying, she worked at St Luke's Hospital in Kilkenny, where she established a podiatry department for the high-risk foot under the National Diabetic Programme. Marilyn has worked at UHL since 2018 as part of the MDT for the acute diabetic foot and has recently completed her Masters in lower limb preservation with the University of Ulster. Thank you, guys.
Today I'm going to discuss diabetic foot disease and the importance of rapid referral to the multidisciplinary foot care team. I will also discuss risk factors and identification and appropriate management of diabetic foot disease. The Diabetic Foot National Model of Care was established in 2011 to provide foot care needs to diabetic patients. Diabetic foot disease has a huge cost implication to the HSE and also has a huge impact on quality of life for patients. The key performance indicators for this clinical programme were to reduce the number of hospital admissions and amputations for diabetic foot complications. All patients should have an annual diabetic foot screening to risk categorize. Patients that fall under low, moderate or high risk are usually managed by the community teams. Patients that have an acute active foot ulcer or Charcot-neuroarthropathy are referred rapidly into the hospital setting where they are managed by the multidisciplinary foot care team. To get more detail on this national model of care, please look at the HSE website. So what are the risk factors for diabetic foot disease? Patients that have already established macro and microvascular disease such as stroke, heart attack or previous vascular intervention, retinopathy or nephropathy, once they have already established vascular disease, they are at much higher risk of having a peripheral arterial disease. Also, patients that have a history of previous ulceration or amputation are at much greater risk of re-ulcerating again. Also, other factors like foot deformity, and as you can see from the picture here, and we'll discuss a little bit later on this patient has got a cavoid foot type, the high arch foot, so there's really plantar pressure areas on the foot, predisposing them to developing ulceration from something as simple as inappropriate footwear. Also, smoking has a huge impact on the arterial supply of the peripheries, so is another factor and risk factor for diabetic foot disease. So why do patients with diabetes develop foot ulceration? This is multifactorial, and as we discussed earlier on, the risk factors involved in diabetes. However, diabetes affects the foot specifically with regard to the neurological and vascular supply to the foot. Neuropathy can be subdivided into motor, sensory and autonomic neuropathy. Motor neuropathy affects the coordination of proprioception and can also cause muscle weakness and muscle imbalance within the foot. Patients can develop a cavoid foot type, which you could see earlier on in the slide. This is where there is a high arch foot and clawing of the toes. This foot deformity can cause shear pressure over the area and the development of callus. Sensory neuropathy, there is a reduction of the patient's ability to feel pain. Autonomic neuropathy can cause a reduction in sweating and can lead to dry, devitalized skin. So a patient with motor neuropathy, that is a foot deformity, together with lack of pain sensation, dry skin, coupled with callus or any minor trauma, can develop foot ulceration without them realising it. If the blood supply is adequate and there is no infection, the majority of these neuropathic foot ulcers will heal with appropriate management and offloading. However, if there is peripheral vascular disease and a reduced blood flow to the foot, this can lead to failure of the ulcer to heal and is at much higher risk of developing infection. Peripheral arterial disease and trauma alone can lead to foot ulceration. However, together with neuropathy, there is a much higher risk of developing foot ulceration that can lead to lower extremity amputation. So to look at this in more detail, when you're assessing a diabetic foot or foot ulcer, you first need to look at the vascular supply. So you've already done your full medical history and you know what your risk factors are. On the assessment, you need to look at the colour. So does it look normal, healthy colour, or is there any discoloration of rubor or cyanotic appearance? Is the foot warm or cool to touch? Can you palpate the pedal pulses? Does the patient complain of any claudication or rest pain? Intermittent claudication is the lack of blood flow and oxygen to the muscles, causing pain to the back of the calf or higher up in the leg when the patient walks at a certain distance. This pain is alleviated when the patient rests. However, rest pain, on the other hand, occurs when the patient is at rest and most often when they're lying in bed or they have their legs elevated. Quite often the only relief that they will get if they hang their legs down or that they walk. This can be together with a rubor or cyanotic discoloration to the limb where it feels cold. And as you can see from the pictures above, there is a discoloration to the legs. This is critical limb ischemia and needs to be seen urgently by the vascular team, even if there is no tissue loss. So your next assessment would be a neurological assessment where you will check sensation with a monofilament and a tuning fork. So when we look at an ulcer in specifically, we look at the size, the depth, whether or not it can probe to bone, whether or not there's a deeper sinus, or are there ulcers connecting. Also need to look, is there any sign of infection? So is there any erythema, any swelling, any tracking of redness up the leg? Is there any deeper abscess further down? Is there a malodour? Is there a high level of exudate? Is there callus surrounding or sloughy tissue to the wound bed or necrotic tissue that needs to be debrided? And also, if it's on a high pressured plantar area of the foot, does it need to be offloaded? There are different types of diabetic foot ulcers. On the left hand side is a typical neuropathic foot ulcer. This patient will have peripheral neuropathy, will have a palpable pedal pulse, a warm foot, normal colour. They may have a foot deformity with callus formation and have ulceration on high pressured areas. With this type of neuropathic wound, with the appropriate management and offloading, you would expect it to heal. In the middle picture, you can see an ischemic wound. You would expect that there is no evidence of peripheral neuropathy, that the pedal pulses are non-palpable or weak. They can have a rubor or mottle-like discoloration to the foot. It can be cool to touch and the skin can be devitalized. The ulcer may present as a necrotic or punched-in wound, and most often it's located around the heel area, the apex of the toes, or under the nails. Usually the ulcer is quite painful and patients may be experiencing claudication or rest pain. A neuroischemic wound has a combination of both neuropathy and peripheral arterial disease. These patients will present the same as an ischemic wound, however, they also have a lack of sensation. And the ulcer can often be located on a weight-bearing area and have callus surrounding. Although the patient may have peripheral neuropathy, they may also still experience claudication or rest pain. Both ischemic and neuroischemic ulcers need to be reviewed by the vascular team and more than likely will require revascularization in order for these wounds to heal. Charcot-neuroarthropathy is associated with long duration of diabetes and due to peripheral neuropathy. In this condition, the bone becomes fragile with a high bone turnover causing spontaneous fracturing and dislocation of the joints, and it can be rapidly progressive. Usually the patient presents initially with a red hot swollen foot with or without pain, and sometimes it can be misdiagnosed as a cellulitis. The management for this condition is referral under the multidisciplinary orthopedic services, and the patient needs to non-weight bear. Usually they are casted into a soft cast, a total contact cast, and are required to offload. Once the active stage is over, they may require fusion surgery. For patients that present with active foot disease, when they attend the acute setting, bloods are required to check their inflammatory markers, their diabetes control, and their kidney function. For patients with wounds, ideally we would like a deep tissue sample or swab of the wound to check the culture and sensitivity, and this is used with regarding what antibiotics may be used. For vascular investigations, ABPIs and toe pressures are carried out. ABPIs in the diabetic foot may not be accurate due to calcification of the vessels, so toe pressures are much more accurate in giving a true picture of the blood flow. Quite often MRA is needed to further investigate blood flow and any blockages. For patients that present with suspected osteomyelitis or Charcot, they require plain x-rays as a baseline and possible MRI for further investigation. For all diabetic foot wounds, they need to be offloaded. This can be done in a number of ways. You need to take a holistic approach to the patient if they're suitable for certain types of offloading. They may be a false risk. Our gold standard treatment for neuropathic foot ulcers and Charcot neuroarthropathy is total contact casting. If this is not suitable, the patient may be provided with an offloading diabetic foot boot or offloading shoes or sandals. Again, this depends on the patient's ability and function. So the management of diabetic foot disease is essentially rapid referral to the multidisciplinary foot care team in the acute setting to begin with. Once they're under the multidisciplinary team, they need to be reviewed and observed for signs of deterioration and wound infection. They may need surgical and sharp debridement or revascularization, and sometimes patients will require an amputation. We may need to use the use of specialised dressings, pressure redistribution and offloading. These patients need ongoing multidisciplinary foot care team management until the area is healed.
Thank you to Elizabeth and Marilyn for that really interesting talk. I am looking forward to those questions you're going to get at the end. So on to our next speaker. Mary McMahon has worked as a general nurse, a midwife and a public health nurse in Ireland and abroad. She completed an MA in Health Education and Promotion from the University of Limerick and also holds a certificate in addiction studies. She has worked in the HSE Health Promotion Department since 2001 as a Health Promotion and Improvement Officer, having previously worked as a regional coordinator for Healthy Schools and a Making Every Contact Count trainer. She is now the Quit Midwest Service Coordinator and the Stop Smoking Advisor. Thank you, Mary.
Hello, my name is Mary McMahon. I am the coordinator and a stop smoking advisor with the HSE Quit Midwest Stop Smoking Service, which is based in the community in Clare, Limerick and North Tipperary. And you're very welcome here today to this very brief presentation on what our service entails. So we're going to look at, I'm going to introduce you to the team, just going to look at some of the issues that drive on the need for stop smoking services. What is the best optimal treatment for quitting smoking? How do you access our service? And then what other services are provided by the HSE in terms of stop smoking support? Just to introduce you to my team members, that's myself at the back, and then to my right is Bernie wearing the red t-shirt, and Anya in front of me, and we all work as stop smoking advisors. And then to my left is Bedelia, who is the service manager. So that's our team at the moment, which we do expect to expand in the short-term future. Just to say that we know the smoking prevalence in the Irish population as of the last Healthy Ireland data survey in 2019 was 17%. We also know that this rate can change very much according to employment levels, age groups, etc. And just to give you an example, that smoking rate is as high as 26% in the age group 25 to 34-year-olds. In terms of diabetes, because that's what today is very much focused on, we do know that people with who are smokers are 30 to 40% more likely to develop type 2 diabetes. And this is very much dependent on the number of cigarettes that people smoke. So the higher the rate of smoking, the greater the likelihood. Unfortunately, in Ireland, we know that smoking related illness contributes to 100 deaths every week in the Irish Health Service, and that is taken from a 2018 study. So, what is the optimal treatment for helping a smoker to quit smoking? The evidence shows that the optimal treatment is a combination of a structured behavioural support programme, and along with that, the use of a medication, an evidence-based medication aid for quitting, such as nicotine replacement therapy or Champix. And again, that's if a medication aid is indicated. So in Ireland, you will see there a standard treatment programme image. We do use a HSE standard treatment programme for supporting quitting attempts. The HSE Standard Treatment Programme for Smoking Cessation is an evidence-based behavioural support programme that is delivered at set time points during the person's quitting journey. Ideally, we like to meet with the person before they quit smoking and to work with that person with where they're at in order to come up with the best plan for increasing the likelihood of the person successfully quitting. So we again meet with the person on their quit date or as near to the quit date as possible, and for the first 4 weeks of quitting smoking we follow through. We also review at 3 months and again at 12 months how that person's quitting journey has gone. To say at the moment that we deliver the service through the option of telehealth or telephone, and post-COVID we will be resuming our face-to-face clinics. So what's the challenge? The challenge really is getting word out there to people who smoke that there is help to quit smoking. And, you know, even for us as frontline practitioners to realise the power of our own intervention, even by raising the issue of smoking with clients. So a recent Healthy Ireland summary report gave an interesting statistic that 7% of those who successfully quit smoking in Ireland during the previous 12 months did so based on the advice of a health professional, and that compared to 1% of those who made an unsuccessful attempt to quit. So it really can increase the odds of quitting. And I'd like to just draw attention that in the busy lives of health practitioners on the front line, even 30 seconds stop smoking advice can be effective. And if you can think of it in terms of ask, advise and act, and I'm sure many people are already carrying out this very brief advice. For those who are interested in perhaps training to address tobacco at a greater level, then we have intensive tobacco cessation training available, and that's available to people who have carried out the training for the Making Every Contact Count. So I have put up the web address there for linking into that training. The benefits of quitting smoking are instantaneous and ongoing. So in terms of chronic disease prevention and management, it is a really important part of the person's care plan. And in terms of diabetes, it is going to so improve their risks of developing cardiovascular disease in particular, and all the other increased risks that they have from not alone being a smoker but also having diabetes as well. And also we know that the insulin will work better in the body when smoking is taken out of the picture. How do you access the Quit Midwest service? Well, we welcome referrals at all times, and we are able to take paper referral or digital referral. A stop smoking referral form can be sent out to you if you'd like to refer clients to the service with their permission, of course. And we also have a central line for 065 6865 841 where we'll take referrals, or you can email referrals to me at maryb.mcmahon@hse.ie. Just to say, we do have a national data management system to support the tobacco service nationally, and this is called Quit Manager, and the referral module for HealthLink is about to go live in that shortly, so you will be able to make direct referrals through that system. So in my final slide, I'd just like to draw attention to a couple of things, and that is that if you are a HSE staff member who would like to think about quitting smoking, please do contact Quit Midwest. We're always available to help, but there is a 28-day quitting challenge for staff, whereby people who quit for 28 days are 5 times more likely to quit for good, and the HSE is supporting its staff to quit by providing free nicotine replacement or Champix therapy as indicated. I'd also like to draw attention to the fact that the HSE offers other forms of quitting support, and these are at national level, where we have free phone or free text. You can join a Facebook community, and as well as that, to remember that at local level you have your health professionals such as your GP, pharmacist or practice nurse. So the final message in leaving you today is to say thank you very much for listening to me, but also to remember that together we can work as a team to help smokers that you meet along your journey in work to make their next quit attempt their last quit attempt. Thank you very much.
Thanks, Mary. Lots of great information there. And as a reminder to everyone, the webinar is going to be uploaded. So if you need any copies of the information that you've seen today in the slides, they'll all be there for you, and you'll be given that email from Eventbrite once it's uploaded. So to our final presenter today, I'd like to welcome Fiona Johnston. Fiona originally trained as a nurse in Hertfordshire, the UK, qualifying in 2002. She completed her nursing degree at the University of Limerick in 2005, and then completed her postgrad degree in diabetes specialist nursing in 2011 at UCD. Fiona has been working as a clinical nurse specialist in diabetes since 2012, and she's based in Ennis, County Clare. Thank you, Fiona.
Hello, my name is Fiona Johnson. I'm a clinical nurse specialist in diabetes in the NSUL hospital. Today we will speak about the management of hyperglycemia and type 2 diabetes. The definition of hyperglycemia is a continuous high elevated blood glucose above 10 millimoles due to a relative or absolute insulin deficiency. Symptoms normally occur when the blood glucose is persistently greater than 15 millimoles. The cause should be sought and corrected to avoid diabetic ketoacidosis and HHS and avoid complications. Some of the causes of hyperglycemia include newly diagnosed diabetes, omission of insulin plus or minus oral hypoglycemic agents, the mistiming of medication or insulin with administration of meals, emotional stress, physical stress, for example, infection, surgery, cardiac events, eating disorders or prolonged fasting episodes, dietary adherence or reduced activity levels. Causes of hyperglycemia include medication-induced, smoking, brittle diabetes, rebound highs from hypoglycemia within the last 12 hours, weight gain, timing of blood glucose testing, hands that are unwashed pre-testing, or alcohol hand gels. Symptoms of hyperglycemia include polydipsia, polyuria, lethargy, blurred vision, muscle cramps, abdominal pain or headaches, feeling unwell, weight loss, recurrent infections, low mood, agitation, breathlessness, sweet breath, nausea or vomiting. When to worry about hyperglycemia. Patients should aim for blood glucose between 4 to 8 millimoles 80% of the time, unless higher glycemic target is given by the medical team or GP. If blood glucose levels are high at any particular time of the day, highlight it with their medical team or with the GP. If blood glucose levels remain over 10 millimoles and continue to rise, patients are advised to seek medical review by their diabetes team or by their GP. If the patient is type 1 diabetic, they are educated to check for blood or urinary ketones if their blood glucose remains over 13. The patients are also educated to refer to the DKA guidelines. Management of hyperglycemia, it mostly depends on the cause. Treat any underlying illness or infection. Monitor blood glucose levels 2 to 4 hourly. If remains elevated, request diabetes nurse, GP or consultant review. If the patient is requiring steroids, they will need to have a diabetic medication review. Check blood glucose level prior to starting steroids. Review the timing of medication in relation to meals. Review the timing of blood glucose testing in relation to meals. Re-educate the patient on insulin regime, injection technique, and sites and storage of insulin. A UK PDS trial which was done showed that a 1% decrease in HbA1c is associated with a reduction in complications. This chart is a great take-home message that even with the reduction in a HbA1c of 1%, how the patients can benefit in amputation or fatal peripheral blood vessel disease by 43% reduction, 37%, 21% in deaths related to diabetes, 14% reduction in heart attacks, and 12% reduction in stroke. It's a lovely slide. The American Diabetes Association position statement update in 2015 in the management of hyperglycemia stated that a patient-centred approach for patients providing care that is respectful and responsive to the individual patient preferences, needs and values, ensuring that patient value guides all clinical decisions. It's to gauge the patient's preferred level of involvement, explore where possible therapeutic choices, consider using decision aids. And also, it's important to make shared decision making a collaborative process between a patient and clinician, using best available evidence and taking into account the patient's preferences and values. Final decisions regarding lifestyle choices ultimately lie with the patient. This slide discusses the approach to management of hyperglycemia. This picture shows the elements of the decision making used to determine appropriate efforts to achieve glycemic targets. Greater concerns about a particular domain are represented by increasing height of the ramp. Therefore, characteristics towards the left justify more stringent efforts to lower HbA1c, whereas those toward the right are compatible with less stringent efforts. Where possible, such decisions should be made in conjunction with the patient, reflecting his or her preferences, needs and values. This scale is not designed to be applied rigidly, but to be used as a broad construct to help guide clinical decisions. This slide is just going to discuss about the HbA1c targets, and in an ideal world our general target would be for a HbA1c less than 53 millimoles, which equates to 7%. Individual targets are key. We have tighter targets for the younger, healthier individuals. That those HbA1c we would be looking for there would be between 42 to 48 millimoles, that would be 6 to 6.5%. We would have looser targets for the older patients with comorbidities. Hypoglycemia prone individuals, so we have looser targets for those people. So we would aim for their HbA1c to be between 58 and 64 millimoles. That's between 7.5 and 8%. At all times we try to avoid hypoglycemia. Oral therapies in type 2 diabetes. The most commonly used in Ireland are the metformin, sulfonylureas, GLP-1 receptor agonists, DPP-4 inhibitors, SGLT2 inhibitors and the thiazides. Some side effects with the oral hypoglycemic agents. Metformin can cause nausea and possible diarrhea. It's important to start off on a low dose of metformin and increase after a month. Caution or dose adjust with a declining EGFR. Sulfonylureas, Amaryl and Diamicron can have a risk of hypos and weight gain. DPP-4 inhibitors, Galvus, Tradjenta and Januvia can cause some nausea, with also a rare risk of pancreatitis. When patients are started on this line of drugs, they are advised to watch out for abdo pain and report it to their doctor. GLP-1s, the injectable devices, the Bydureon, the Ozempic, the Victoza, these are once weekly injections. They can cause nausea, again rare risk of pancreatitis, and to watch out for abdominal pain, and the patients again are educated on informing their healthcare professional on any of these risks. SGLT2s, these are an oral tablet taken once a day. The names are Forxiga and Invokana and Jardiance. These can cause genital infections, thrush in both men and women, and also carry the risk of kidney infections. Again, patients undergo education before they start these medications, and they're advised to let their healthcare professional know of any side effects. Insulin can have risk of hypos and weight gain. The DPP-4 inhibitors, these include linagliptin, which is Tradjenta. It's a 5 mg daily, no dose adjustment required in chronic kidney disease. Linagliptin and metformin in combination is Gentaduetto, and that can be used in 2.5 to 850 mg twice a day, or 2.5 mg / 1000 mg twice a day. Sitagliptin, which is Januvia, is 100 mg daily. This does have to be dose adjusted. In an EGFR between 30 and 50, you have to reduce the dose to 50 mg daily. With an EGFR of less than 30, it's 25 mg daily. Again, sitagliptin and metformin comes in a combination called Janumet, and the doses are 50 / 850 mg twice a day, or 50 / 1000 mg twice a day. Galvus is 100 mg daily. It's to be reduced to 50 mg daily if an EGFR is less than 50. The combination is vitagliptin and metformin, which is Eucreus. The next one is Onglyza, which is 5 mg once a day. This is to be reduced to 2.5 mg once a day if the EGFR falls between 30 and 50. Again, the combination is saxagliptin and metformin, which is Combidlyze. It's important to note that recommended glycemic goals are achieved by less than 50% of patients. Adherence rate decreases with larger numbers of oral hypoglycemic agents, doses to be taken. Mean adherence to once daily regimes is 79.1%. To twice daily regime, it is 65.6%. But when we increase the medication regime to 3 times a day, it reduces right down to 38%. Adherence is a big issue in our everyday practice with our patients. 2/3 of our patients do not adequately comply with metformin and sulfonylurea therapy. Improving compliance with patients. Advice on mechanism to keep costs low, the long-term illness form, is important to establish with the patients at the very start. This would help them to get the medication free. Develop a scheduled time to take your medication. Make sure your medication is on hand at all times. Advise the patient to remind themselves with notes, checklists, set self-reminder, apps or blister packs from the chemist are very, very useful, and have a supportive network, family or friends who can motivate you to remind you to take your medication. Improving compliance with the healthcare professional. We'd start by simplifying the regimes for the patient. Try to match the regime to patient activities if possible. Ask patients about the consequences of not taking their medications. Have patients restate the positive benefits of taking their medications. Ask about adherence at every clinic visit. Periodically review patients' medications containers, noting renewal dates. Advice on mechanism to keep medication costs low. Use medication adherence scales, for example the Meriski 4, also known as the Medication Adherence Questionnaire. The education to patients on insulin should include starting at the very beginning, establishing what is their knowledge of diabetes, what the consequences of high blood glucose does to their body, getting control of their diabetes and monitoring control of their diabetes. The importance of needle change after one use is always stressed during the education session. Increased injection, pain and injuries. Tissue hardening can happen Injuries or even bleeding at the injection site may lead to tissue hardening or lumps of fatty tissue. It's important to note with patients that to rotate the injection sites is very important to avoid infection, needle clogging and inaccurate dosing. In conclusion, early aggressive management is very important when it comes to newly diagnosed type 2 or type 1 diabetes. A patient-centred approach is always very important when it comes to dealing with patients of all ages. Simplifying the treatment, education and intervention, and compliance with medication. Thank you for listening to my presentation.